Welcome to another edition of Inside the Training Room. This week we're going to talk about foot and ankle. I want to welcome Dr. Ellington.
Hey, thank you for having me on. Excited to talk about all these issues.
Okay. First of all, let's start with some basics first. Can you walk us through what the anatomy of the foot is?
Sure. So, as you mentioned, I'm an orthopedic surgeon with the Foot and Ankle Fellowship uh, interest, and I did it's one of those things to me, that in a kind of a prideful way, take strong interest in the anatomy of the foot and the ankle because it's so complex. And I like to joke along with my other partners, that are hip docs or knee docs, that they're just dealing with a couple bones and one joint, but the foot is very, very complex, and it's quite remarkable structure. It's got 28 different bones, which that comprises about 25% of the bones in your entire body. It has 30 joints, and there's over 100 muscles and tendons and ligaments that attach to those different bones and joints in the foot. And all these things work together to provide support, stability, balance, and mobility, and explosion, which is what the athletes are really interested in when they're out there on the court or field playing. And so it works in all these very intricate, small, complicated things work together to create a pedestal for the human body to be able to do, easy standing and walking locomotion to excelling in all types of athletic endeavors.
Yeah, and I think over the years I've probably hurt all 28 of those bones and joints and muscles. So moving up, another favorite part of my anatomy is the ankles. Can you talk about the anatomy of the ankle too?
Yeah, so the foot, is in basic terms that tripod of the heel, the big toe, and the smaller toe, and they all come together to form joints in the midfoot and the hindfoot, and then the joint below the ankle called the subtalar joint, and that joint is responsible for side-to-side motion. And then on top of that is the ankle joint. And the ankle joint is what the shin bone comes down and attaches to the foot. And the ankle is uh, kind of like a square looking joint, and it has the inside part, which we call the medial malleolus, and it has the outside part called the lateral malleolus. And then it has the talus, which is a foot bone that sits under the shin bone. And that complex of bony anatomy creates the ankle joint proper. And it's really important because when people talk about having an ankle fracture or breaking their ankle, in generic terms, they're talking about breaking that inside bone, that medial malleolus, or that outside bone, the lateral malleolus. So that forms the ankle joint. And then around the joint of the ankle are two very important parts that are ligamentous. And one of those is called the syndesmosis. And so that's frequently referred to as when patients or players have an injury, they call it a high ankle sprain. And that's where they sprain the syndesmosis, which is the ligament that connects the shin bone and the fibula together. So there's two bones in the lower leg, the tibia and the fibula, and the syndesmosis connects those two bones together. And if you sprain that, that's called a high ankle sprain. That's a common thing you hear about in sports. You see it on ESPN a lot. And if you tear that, then that's just as bad as an ankle fracture. If you tear the syndesmosis, that's not a sprain. That's a full-on tear. That requires surgery, just like if you broke your ankle, you broke the bones. And then there's the ligaments on the inside and the outside of the ankle that are commonly referred to as, the ankle ligaments that you sprain when you twist your ankle playing sport, or you fall off a curb or twist it on a step. So when you sprain your ankle, those ligaments on the inside and the outside are really important to the stability of the overall ankle anatomy.
Okay. And so a lot of moving parts in there, and they all carry the weight of our bodies. So a lot that can get injured. Talk about some of the common injuries that you see to the foot.
Yeah, so I mean, well said. There's a lot of moving parts, and because of that, unfortunately, there's just a lot of ways you can hurt your foot. And so if there's a bone, if there's a ligament, if there's a joint, if there's a tendon, etc., any of those things can be hurt in the foot. And the common foot injuries are one of the most common ones we see in athletics is a Lisfranc injury. And the Lisfranc is one of those ligaments I talked about that connect the bones together inside the foot. And it's really, really important to the stability of the foot. And it helps provide force from the heel to the forefoot. And so imagine if you're running or jumping or cutting, you're transmitting force from your calf muscle down to your heel, through your midfoot to your toe, so you can push off and have that explosion. When you have a Lisfranc, you have a disruption in the middle of the foot, so you lose the ability to transfer that energy and push off and have that explosion. And that Lisfranc injury is that ligament resulting in instability of the midfoot. And when a patient has that, we fix that with surgery. That's one of those things that, unfortunately, if you have this type of injury, it results in surgery. In fact, I fixed 2 yesterday in collegiate football players, one in an NFL player 2 weeks ago, and then I saw a guy today in clinic, another collegiate football player who tore his Lisfranc. So just in 2 weeks, I've fixed 4 people at different levels of athletic ability due to tearing that ligament. So that's a real common one you see, again, one of those ESPN ticker tapes, around here in Charlotte, famously, Cam Newton had a Lisfranc injury last year. So in addition to that, another common injury that we see in athletic population is when patients have an injury to the bone in front of their ankle called the navicular bone. Most commonly, we see that it's a stress reaction or stress fracture in the athletic population. Now, luckily, a lot of times those things can be treated non-operatively, but if it doesn't heal because that particular bone doesn't have a good blood supply, it can go on to have continued pain and then need surgery. In addition to those, another common thing that we see in the athletic population is something called a Jones fracture. And that's a fracture where you break the base of the 5th metatarsal. And likewise, that bone, kind of like the navicular, has a very poor blood supply. So when an athlete breaks that bone, that pretty much always results in surgery as well, because they don't do too well with non-operative treatment. And again, a Jones fracture is one of those other common fractures you see about on the ESPN ticker tape, because it's a common fracture along with Lisfranc in plaguing collegiate and professional athletes. In addition, turf toe you hear about a lot, and that's where you kind of tear the ligaments under the big toe, and that can cause the big toe not to function properly. And in a normal dude, that might not be a big deal, but if you're a runner or athlete, basketball, football, soccer player, tennis, volleyball, whatever, where you really do a lot of running and cutting, injury to the big toe can be a devastating injury. It's ended many people's career, even at the professional level. So it's a big deal to have a turf toe. And under the big toe, there's 2 bones called the sesamoids. These little bones, they're like the size of peanuts. Even they're small, but they can cause some problems. And we often see those patients having injuries with these particular bones in runners and dancers and cheerleaders, where they do a lot of pressure on their forefoot. And then, like you kind of said, those are the more common ones, but then if there's a bone in the foot, it can be broken. So any of the other fractures can happen. Now, luckily, those other ones oftentimes can be treated non-operatively. In addition, you can dislocate the foot. There's several different common dislocations that occur in the foot. Most commonly is the joint below the ankle called the subtalar joint. You see that can happen. More commonly seems to be in football, baseball, and basketball, and dislocating that joint. And then lastly is stress fractures. And this is a common thing we see in athletes, especially in today's way that they train. And everyone that's trying to make it to the next level really puts a wear and tear in their body, and they can overtrain and overwork. And so it's not uncommon to see guys and girls come in that are 14, 16 years old, just really pushing their bodies to the limits. And in fact, I saw a girl last week. She's 16, high school track runner, and she's trying to be the best on the team, and I commend her for it. But she had a 3rd metatarsal stress fracture, where just too much literally just broke. And so stress fractures can occur in the foot as well.
Yeah. And then onto the ankle, not as many parts there, but I think everybody that's ever walked or run has twisted their ankle or strained their ankle. What kind of injuries do you see there?
The most common we see is what you just mentioned, is the ankle sprain, and that could be something where you just kind of tweak your ankle playing basketball. You come down on some other player's foot, or happens in soccer a lot, where you just kind of sprain the ankle, and it's bad for a few minutes to a few hours, and it's better after that. Most ankle sprains do last anywhere from kind of 2 to 4 weeks, and they rehab on their own. The trainers and the therapists do a great job in getting those patients back on the field pretty quickly. The problem with the sprain is that same ligament, if it doesn't heal properly, and in about 10 to 15% of the time it does not, that ligament loses its strength, and it's really loose, and that causes instability to the ankle, and then we have to go in there and fix that. So like if you tear your ACL, right, that's a ligament in the knee, that we always fix that. Well, if you tear the ligament around the ankle, if it heals on its own, again, about 90% of the time it will, you don't need surgery. But if it tears and doesn't heal, then you do need to repair those ligaments. You can break your ankle, as I kind of mentioned to earlier. You can break the inside, you can break the outside. Oftentimes we fix those. Occasionally you can have an ankle fracture, does not require surgery. And then as any joint, you can dislocate the ankle, and that's pretty uncommon injury, but ankle dislocations do occur. And in any joint also, you can have a cartilage injury. And we see this pretty commonly in athletes, where if you have a really bad ankle sprain, it twists the ankle so bad that not only does it tear the ligament, but as I mentioned, the ankle's kind of like a square. And imagine, it does great when it's going up and down, but it doesn't like to go side to side. So when it goes side to side too much, you can actually tear the cartilage inside the ankle joint, and that can be a problem that can require surgery. And then there's tendons all around the ankle. So there's the Achilles tendon, there's tendons on the outside, there's tendons on the inside, and they can be injured through just kind of micro trauma over time, or you can have a full out rupture and require surgery in those situations.
Okay. So because ankle and foot injuries are fairly common in everyday life, how do we know when it should be evaluated, and how much time should go by before we head in, if we're kind of wondering, well, maybe a day from now it'll get better and I won't be hobbling around as much? What kind of indication should a patient look for that say, I need to go see Dr. Ellington?
Yeah, so your comment about the commonality of it, it's quite interesting. So 45% of all injuries that occur in the athletic population are to, so that takes into consideration hip, knee, wrist, shoulder, everything. So 45% of all injuries are in the foot and ankle. So they're very, very common, as you mentioned, and that's a big part of my practice. And it's an enjoyable part because I love taking care of people who, have an injury, and we can get them through without surgery. And then there's that occasion they do need surgery. So the times you need to come in and be evaluated is if you felt or heard a pop, that something happened, right? So if you felt or heard a pop, either a ligament tore, a tendon ruptured, or a bone broke. And that doesn't mean it needs surgery, but if you felt or heard a pop, then something definitely is not right. So I think if you had that situation, it's probably a good idea to get evaluated, especially if some people can feel a pop and have a problem, and in a day or two, it's feeling a lot better. You could probably hold off on that, but it's always better to be safer than sorry. If you have swelling, it doesn't improve. So if it's been a couple days and the swelling just not getting better, you just don't see a difference in the swelling of the extremity or the color, it's something to get checked out. If you feel like it's unstable, that you can't trust it, or you can't put any weight on it, the inability to put weight on the foot is a telltale sign that there's something pretty bad. And if you have done these things and you felt the pop and you kind of did the rice treatment yourself, and you felt like you're kind of making some progress, and you're trying to get back to being an athlete or just recreationally, and you feel like you can't accelerate or decelerate like normal, those are other signs for you to come on in and be seen.
Okay. And then once somebody comes in to see it, what's the evaluation process look like? What are some of the things that you do, and maybe tests that you run to determine the nature of the injury?
So we always start out first with a thorough history, talk to the patient, what happened, how did it happen, when did any circumstances around it, did anyone witness what happened? Sometimes players will bring in video of a tape of what happened. Those things are really critical to understanding the kind of the mechanism of the injury. After obtaining the history, we do a thorough exam. standing exam, seated exam, palpation, and stress testing of the ankle, leg, and foot to evaluate if there's any instability or torn ligaments or tendons. We take x-rays all the time, and really strongly suggest standing x-rays. So a lot of patients may come in with an x-ray taken in urgent care or the ER, and unfortunately they're inadequate to really assess what's going on. So if you've had those, we'll repeat them, we'll get standing x-rays. And then after that, depending on what's going on at that point in time, after the history exam and x-rays, depending on how long it's been since the injury, if it's been probably 2 to 3 months and you're not making progress, then we'll order an MRI. That MRI is great at looking at cartilage, the tendon, the ligaments, the bone, in much better detail, and give us a better assessment of what's going on, and is there a role for continuing to rehab, or is there a role to switch gears and move towards surgery?
Yeah, you touched on it just a second ago about the different kind of treatment options. Can you run through those from the range of like the minimal to most radical as far as surgery goes, or as far as treatment goes?
Sure. So, my job as a surgeon is to treat people without surgery. I say that line 30, 40 times a day. And so that's what we're here for. We always want to be conservative. So we start off with giving people some basic rehab to do at home, the RICE treatment, rest, ice, compression, elevation. Our physical therapists who are really talented at helping patients with pain and swelling and getting their strength back and their proprioception and balance back. Sometimes we'll use anti-inflammatories by mouth or creams, and occasionally we'll do an injection of an anti-inflammatory such as a steroid. In addition, we'll do some taping and bracing to help support the ankle or the foot. And then if all these things don't get us where we want, we can use sometimes customized bracing or even custom orthotics to support the foot. And then our last option is if those things don't work, or depending on the overall diagnosis, we'll move to surgery. And so simply, if the joint's dislocated, we'll pop it back in. If the tendon's torn, we'll fix it. Same for the ligament and same for the bones. And the goal is to restore the anatomy, because anatomy is function. And so what we want to do in orthopedic surgery is put the anatomy back together the way it was pre-injury, so the patient then can have restored function to get back out there and do what they enjoy doing.
One thing I've learned about OrthoCarolina in this series is the emphasis on prevention. And there are things athletes can do to help themselves prevent these injuries. What are some of the things that you would recommend for athletes to do to prevent foot and ankle injuries?
So take advantage of your physical therapists and your trainers and your coaches and friends and colleagues, and listen to your parents, and it's important to really focus on strength conditioning. The science of strength conditioning has expanded dramatically over the last 10 to 20 years, and it's incredible what we know about the human body and how it reacts in different situations on the playing field. And so you really want to focus on that and training. Core strength is really important. It's something that people like to ignore and put off last, or they'll skip it and they'll do it the next day, the next day, the next day, and the next thing you know, never doing it. And you really want to work on core strength and balance. Stretching is important, and there's a little bit controversial at times, but I do think stretching before and after can be helpful. If you do have a little sore area or something you can't really truly rely on, then bracing can be helpful, and taping to help prevent further injury to get you through the season. And then it's hard to do, but some of the best people do it, and that's playing control. And there are people out there that have played all through middle school, high school, college, and pro, and never been hurt. And they seem to just know how to, control their body and avoid certain situations. And you want to be intense, you want to be impactful, but at the same time, you do have to have some sense of playing within your bounds. And I think that combination of things can help increase your ability to perform and prevent injury.
All right, that's terrific. I really love the playing and control. I wish somebody had told me that many years ago. Probably could have taken a little wear and tear off of my feet and ankles. Dr. Ellington, we really appreciate you joining us. We're going to talk to some physical therapists now about treatment and prevention, and then Dr. Ellington will be back at the end of the stream to take your questions and answers. Thanks. All right, thank you, Dr. Ellington. And now we've got Hanna Moore and Jeff Harmon, who are physical therapists at OrthoCarolina, and they're going to walk us through some of the rehabilitation and prevention of foot and ankle injuries. So, Hanna, why don't you tell us what to do?
Yeah, so a couple of the common injuries we see, one of them would be ankle sprains. That's something that occurs when someone rolls their ankle, whether inward or outward. And what happens is those ligaments that connect all the bones together in your foot can either get stretched out or torn in that injury. So patients can expect things to be painful, swollen, sometimes bruised, and they can have some difficulty walking. And in that case, we encourage people, if it's a very difficult time to walk, to, of course, go and get checked out by a medical provider, maybe get some images, some x-rays, and make sure there's no fracture. And then after that, they can kind of begin weight bearing is tolerated. Walking with like an assistive device if needed, a crutch or something like that. And of course, use the RICE principles for swelling and pain. So that just stands for rest, ice, compression, and elevation. And then we have some strengthening exercises that we recommend, as well as some balance training. And that just encourages the ankle to heal, to get out of that inflammatory period, and then get stronger and more stable. And if they continue to have ankle sprains, someone that with like chronic instability or recurrent sprains, we suggest using some sort of brace just to kind of supplement that stability.
One of the big things that happens with these is with any type of injury, we end up losing a little bit of strength around that area. So one of the first things we do after we reestablish some normal range of motion is to get those small stabilizing muscles working a little bit more efficiently, which allow us to counteract that weakness now that those ligaments have been stretched. So that's one of the big things that happens with our gait. We lose a little bit of that stability, and that's why it always feels like we're going to get some another rolling episode or something to that effect. So that's why the biggest thing we can do is get a lot of that strength back in through there. Another area that we need to work on after we get some of that strength back in, reestablish that range of motion and get that swelling control, is if we can get that balance aspect of it as well. So big fancy term is proprioception, which just means where we are in space. So our foot has to hit the ground, and we have to be able to react to changes in topography in the ground itself, or if we happen to misstep, if we're wearing flip-flops and our heel comes off the edge of that flip-flop, if we don't have that proprioception, we end up rolling that ankle again, which could lead to further injury or even cause the initial injury itself.
Okay.
But we'll run through a couple of different exercises to begin that strengthening phase, if you will.
Yeah, we have a couple of exercises we can show you. One easy ankle strengthening exercise we do is a resistance band exercise in which we work the muscles on every side of the ankle. So I'm going to kind of walk you through 4 directions that you can do with this band. So the first direction would be just to point straight down. So straight up and down. And you could feel that kind of work in the calves and the muscles on the back. The second direction would be to go straight up. So I usually have the patient bring his other foot up, hook it around that foot as an anchor, and then just pull upwards towards the tension. So you had downward, and now you have pulling upwards. Okay. And then you can stay in this position for the third exercise and just let the foot fall inward towards the tension and then bring it outward away from the tension. Now you're working the muscles on the outside. And then the last one, you're going to cross that leg over, keep the band hooked, anchor it around your opposite foot, and now bring the foot inward. So you did all 4 directions, down, up, out, and in. You've covered all the muscles and tendons that surround the ankle. Now, I would recommend doing this a couple times a week, 3 to 4 times a week. You can adjust the resistance depending on how tight you pull the band. And typically a good number of set and reps would be about 2 to 3 sets of 15. So one way to work on balance training to incorporate more stability exercises is to do single leg balance. So you may want to get with a therapist first to determine if this is appropriate for you at home and if it's safe. But typically for our younger athletes, this is something they can handle. So just working on standing statically, keeping your balance on one leg. Now, if that becomes easy, a progression would be to put something soft underneath your foot and make the surface more compliant, which would challenge stability. Now, most people don't have a foam Airex pad at home like we use in here. So something easy you can use is a throw pillow off your couch or one off of your bed. And that'll make the ankle kind of have to waver a little bit more and challenge the stability there with having a soft surface. And you can do this for time, kind of practice for somewhere between 30 seconds and a minute. You could even make this challenge, a little more challenging by adding a dual task, something like throwing and catching a ball, either from you yourself to another person or just between yourself, just kind of like up and down in front of you.
Then, well, another classic ankle injury is a overuse injury, Achilles tendonitis. It happens a lot when it's not a aha moment when we have that injury. It's more of, oh, hey, I've started to have a little bit of pain, and then, oh, it'll go away, and it continues to get a little bit more, and then 6 months down the road, you go, oh, wow, my ankle in the back of it really, really, really hurts. It's just that overuse that we continue to do, because every time that we go into a toe off position, when we walk, we fire that calf muscle, and the Achilles tendon is what attaches our calf to the bottom of our heel. So we just get a lot of irritation in through there, and it just sits around and just festers for quite a bit of time. And it can be a pretty uncomfortable sort of injury.
So one of the best ways to treat Achilles tendonitis is by doing eccentric heel raises. And that's a fancy way to say focus on the lowering down portion of your heel raise. So you can do heel raises multiple different ways. You can do them on a calf raise machine at the gym. You can do them standing on the edge of a step on a staircase, or you can do them on a leg press with your knees extended, just focusing on the ankle movement. The evidence says that you should do these at a very heavy load and at a slow speed. So every time you lower down, we recommend it take about 5 seconds or so to lower down. And you can do these a couple times a week, 2 to 3 times a week, about 3 to 4 sets of 15 reps. We can demonstrate that now if you'd like.
For eccentric raise, you'll go up on both feet, then you'll take your injured one and then slowly come back down to the ground. So it's both feet up. That way you decrease all the force going through the injured side, and you split it, and then you control it on the way down so that that's your eccentric loading positioning through there. So this is probably the easiest one to do because you can just use a kitchen countertop versus having to have a step, or as Hanna was saying, also the calf raise machine at the gym. So as long as you have a surface that won't slide away from you if you put that pressure down, you'll be in good shape with this one. And then you can also do it with the band like we previously demonstrated with the ankle sprain, where if you put it around here and you have your anchor point and then you come up against the resistance and then it's controlling back down, you can even see I have a little bit of a shake as I come down because I'm trying to eccentrically control myself, and I don't have the greatest, it appears. So apparently I need to work on this a little bit myself. So that's another easy way we can get some eccentric loading in through that tissue.
Right. So in addition to strengthening the Achilles tendon, you do want to stretch it as well. So this is a calf stretch. I'm stretching my back leg. My knee is straight and I'm lunging forward till I feel that stretch in the calf. So stretches should typically be held for at least 30 seconds. If you hold it longer, that would be great. And doing a couple of repetitions would be good as well. Now, you'll want to stretch the calf, as I am now, but there are two muscles that make up the calf muscle. The first one is the gastroc, that's what I'm stretching right now. And the second one is the soleus, which you have to stretch by slightly bending that back knee. So you're going to feel that stretch a little bit deeper towards that Achilles tendon heel area, okay? So you'll want to do a couple stretches with the knee straight, as well as a couple stretches with the back knee bent.
All right, before we move on, I want to remind everybody that they can put their questions in the chat, and in a couple of minutes we'll do question and answer with our physical therapist and Dr. Ellington. But the next thing we want to talk about is plantar fasciitis, another common injury. Hanna, tell us about that and some of the treatments that go with it.
Sure. So plantar fasciitis is inflammation of the fascia that's in the arch or the sole of your foot. It connects your heel bone to your big toe. And that just occurs over time, either from poor shoe attire or sometimes increased body mass index, so overweight. It's pretty common that we see most people complain about the first steps in the morning are the most painful, getting out of bed. So things we do to work on plantar fasciitis would be like massage to the area. We have therapists will do that for the patient, or we teach the patient how to do it themselves with like a lacrosse ball or a tennis ball, or even a frozen bottle of water. All of those are great ways to kind of roll out the sole of your foot on some kind of firm structure to massage the area. In addition to that, we recommend seeking out orthotics, whether they are prefabricated, meaning like off the shelf, or custom. We recommend night splints, which is something that they can sleep in. So those first steps in the morning aren't quite as painful. And then we teach them some stretches, like previously shown for the Achilles tendonitis, the gastroc and the soleus stretches, the two calf stretches. And we encourage shoe rotation, especially for those that are on their feet all day long. You don't want to wear the same shoes every single day because this is a overuse or repetitious injury. So you want to expose your foot to different stresses throughout the day or throughout the week, so you don't keep going through the same motion and keep re-irritating that plantar fasciitis. So finding a shoe that's supportive is important, but also maybe kind of switching it up throughout the day if you're someone who works constantly on your feet.
Here's a question for you, Ann. I don't have a lot of experience with it, but what do you think about high heel shoes? Is that an option or no?
Well, us ladies love them, but it definitely puts your plantar fascia in a shortened position. So adequate dorsiflexion, which is that toe up motion, is needed to de-stress or take some of the stress off of the plantar fascia. And the high heels are going to make you very tight, unfortunately.
One of the things that we like to teach our patients is just taking a run-of-the-mill tennis ball. It can be a lacrosse ball, a baseball, softball, something that's got a little bit of diameter and a little bit of mass to it. But you don't want to use a golf ball. It's too small. It's too hard. It's really uncomfortable. And then what you'll do is you'll start by putting a little bit of downward pressure onto the ball towards the heel, which is one of the areas of the plantar fascia attaches. And then you'll just roll it all the way up towards your big toe, and then just rinse and repeat. Now, if you don't have one of those balls, you can always freeze a bottle of water and use the same exact method as well. So you'll just go from heel all the way up towards that toe. And that helps to stretch that area out. So, and you can do this for several minutes at a time. It doesn't have to be a 30-second or a minute. You can just roll through an entire commercial break if you're watching a television show, which usually is 2 to 3 minutes or something. So you can do that several times a day, even if you'd like to. It just really helps to break up that soft tissue that's really started to knock down quite a bit.
So plantar fasciitis, you'll use the same stretches, the gastroc and the soleus stretches I previously demonstrated for Achilles tendonitis. But one extra component you can add to your stretch is take maybe a roll of towels. You guys may not have a half foam roll like we do here, but take something just to kind of extend that toe a little bit more And that will really pull through the entire plantar fascia because you're stretching it across all joints that it attaches to. So instead of having your foot flat, you're going to have your toes a little bit extended into a stretch, and then just lunge forward like a normal calf stretch. And that just stretches it a little more intensely.
All right, very good, you guys. Thanks for that update. Right now, we want to convert over and start answering some of the questions you guys have put in the chat. We'll get Dr. Ellington to join us. All right, everybody, we want to welcome you back into the chat regarding ankle and foot injuries, and we want to welcome our physical therapists back in, Hanna and Jeff, to answer your questions. Guys, one of the first questions that we got asked was, what's the normal amount of time if you do injure your ankle and it's swollen, that it stays swollen before you should consider going to see a doctor? Hanna, if you want to answer that one.
Well, that is tricky. It does vary kind of person to person, swelling. And obviously with the severity of the injury, that can vary as well. The foot and ankle is hard with getting the swelling out of that area because it's the furthest point from your body. So you may see as you increase your activity level or try to, the swelling actually fluctuates and you get some back, and then you ice and you elevate and the swelling goes back down again. So you may kind of see some fluctuations. It may take a good couple of weeks before the swelling completely resolves.
Okay. Dr. Ellington, you've joined us now. Talk to us about patients and swelling and what they should look for before they come to see you.
Yeah, sorry for being late. I just got out of the OR, so changed real quick. So swelling, is one of the most difficult things we have to deal with, and I tell patients when they have swelling, or when they have an injury, or if they have surgery, it's probably the last thing that's going to go away. And it's important to set that expectation up early, because if they still have swelling at 3 or 4 months after an injury or surgery, they start getting concerned. So I think it's important to understand that it's normal, and it can be a year or more, honestly. And that and the problem with swelling is that it causes pain, and swelling causes stiffness, tightness. And when someone has that stiffness, tightness, that results in functional impairment. They have decreased range of motion of their extremity or joint that they're dealing with. And then when they go out and exert themselves, whether it's, sporting or recreation or just standing at work all day, that causes more swelling. And then so it's this bad cycle. And the things that they should, look for before coming to see us is the swelling characteristics, what's it's related to, what helps it. You can do ACE wraps, compression stockings, anti-inflammatories, ice, and elevation are kind of the mainstays of treatment. And that's what we really lean heavily on, both the patient and therapy and training rooms to really help the patient deal with that swelling. Because oftentimes, I'll do a surgery on someone, fix a broken ankle or broken foot, and they, at 2 or 3 months, orthopedic standpoint, look great. The bones look great. The x-rays look great. And they're trying to get back at it. And the thing that really slows them down is the swelling. And so the training room and therapy is really critical in taking that patient to the next level and making them, go from a good outcome to a great outcome.
All right, we've got another question in the chat from Margaret asking about thoughts on athletes screened for orthotics as in some colleges. Do you think it helps prevent injury? Or should they wait to have an issue, Dr. Ellington?
There actually is a great study showing that custom orthotics can decrease the rate of stress fractures. I think there's some orthotics may or may not be perfect for everybody. Custom orthotics definitely are not cheap, but they do fit your foot specifically, and that there's some advantages there. But they have been demonstrated to decrease stress fractures, and that's really common in endurance athlete, runners. But we definitely see them in football players and tennis players as well that are after overtraining. The biggest problem with orthotics is shoe fit. And so for a lot of athletes, specifically soccer players, their feet or their hands, track and field, they argue about, a shoe, how many ounces it weighs. And so you put an orthotic in that it can be a difficult problem to deal with. But I do think, and then so that's for the normal foot. And there are people out there that have a low arch foot or a high arch foot. And those patients, it probably does benefit them to have an orthotic to deal with their foot posture if they don't have a quote unquote normal foot.
Okay. A question for Jeff. When you see people with Achilles injuries, are they more susceptible to have that injury again in your experience?
It can happen that way for sure, especially if we don't take care of some of the underlying issues. Like, for instance, there's a lot of weakness in through that region, or there's an overstress through the area. They can easily re-injure it. It's not one of those things where it's a one and done sort of situation. So as long as we continue to build everything back up, the chance of a re-injury does decrease with that. That is one of those that can easily creep back in if we don't take care of the overall impairment correctly the first time.
Okay. Hanna, we've got a question about somebody, if you have any advice for dancers who practice point.
Any advice for dancers that practice point? Well, dancers in general are very flexible individuals. And we do see that they are in more of the ankle sprain population and recurrent ankle sprains as well. So once they sprain it or stretch out those ligaments, we see that they continue to kind of roll that ankle and suffer continued instability. So my recommendation with them, if that's something that they're going through is instability, to look into bracing and stability of that ankle to control all of that motion that they have available. So getting on a good strength and stability program would be appropriate for them as well.
Okay. We've gotten a couple of questions about bunions in the chat. And Dr. Ellington, if you could talk about that in the treatment, it may not necessarily be in the realm of what we're talking about today, but, they should see an orthopedist and what your advice is for people that have them.
Yeah, Hanna and Jeff, you know the pain. So that's a loaded question. First of all, I tell people all the time, if your bunion doesn't bug you, it doesn't bug me, leave it alone. And so you want to avoid bunion surgery at all costs if you can. Now, granted, today I did 2 bunion surgeries, right? So, but those patients have often on our treatment, they've been through everything. So first, try to avoid surgery. Bunion surgery is very painful. That swelling issue that they were talking about earlier is very real in bunion and forefoot surgery. And so that's that. Number 2, athletes with bunions are a bad mix because we typically tell athletes that have a bunion to avoid bunion surgery until they're done with their career, whether that's high school, college, or professional, because it could be a lethal blow to an athlete if you have bunion correction. Not in all cases, but definitely want to be careful about that. And then, for anyone else, there are all kinds of bunions, and that means there's all kinds of surgeries. And so every single bunion, it sounds kind of dorky, but really does require a specific exam and X-rays, and then evaluation is really important on the foot posture, the patient's age, their activity level, their range of motion of their foot and their ankle, what they're looking at, what their expectations for bunion surgery is. And all those things go into like, okay, well then this particular patient gets this bunion surgery and this one gets that. So we at our academic meetings spend hours and hours talking about bunion surgery. It's pretty complicated, but it definitely takes a detailed approach. And if anyone's got a bunion problem, we'd be happy to take care of you and see you. Me and my partners all do them, and then when they get stiff and swollen afterwards, we send them to therapy.
All right. Who knew that bunions were so complicated? Hey, Jeff, do you have anything to add about that, about what patients can do maybe preventatively or to treat bunions that they have? Jeff, did you hear the question?
I did not hear the question. It was fading in and out.
Oh, okay. Do you have, in your experience, people with bunions, do you have any advice for them on preventative or things that they can do to help them feel better?
Unfortunately, there's not a whole lot of preventative stuff. Once it's there, it's kind of there. And then if it starts bothering, then we send them to Dr. Ellington. Our main focus at that point, though, is to try to, if there's a gait issue. So, for instance, if they've started to modify their gait to come off of that irritated area, which can start causing other things up the chain further. That's really what we do so that we can try to prevent some of that. There are some things, a little bit of like a spacer every once in a while. Some people will come in with some wacky thing they found on the internet that sometimes might help them with it. But as far as an actual, once it's there in kind of our area, there's not much that we're going to do to make any sort of significant correction to it.
Okay. Dr. Ellington, another question for you about bone spurs. Somebody asked, they have them in their heel, sometimes inflames their Achilles. When do you recommend seeing a specialist about bone spurs?
Yeah, so if you have that bone spur in the back of the heel where the Achilles inserts, that has a specific name. We call it a Haglund's deformity. It's a common thing we see in 50s and 60s-year-old, but it definitely occurs in other people. In fact, I just operated on a professional basketball player a few weeks ago that had it. So, it's a wide range of age that can occur in, but it's a spur right on the back of the heel. Hold on one second. I keep my trusty model, for
that's outstanding.
So this is your foot, right? And then so your calf muscle's here, and it comes down and turns into your Achilles tendon, and your Achilles tendon inserts right here, and that little spur there can dig into the Achilles. And we always Achilles surgery is no joke, as Jeff was talking about a second ago, and it doesn't matter if you rupture it or if you have an Achilles spur, it's a big deal. And so every single patient we see with a spur on their Achilles, we tell them go to therapy and work on stretching, and not just twice a week did you go to therapy, but do it 10 times a day. You teach them some exercises to do in the clinic, and then the problem is everybody wants somebody to fix their problem, right? And this is one of those things that really focuses on therapy and stretching. The calf muscle is tight and it's pulling on that spur, it's not helping things. And so studies show that if you go to therapy, you listen to your therapist, you do what they tell you, you have an 80% chance of avoiding surgery. If that doesn't happen, what we do is we open up the back of and I did this case today as well. You make an incision on the back of the heel, you remove the Achilles tendon because the spur is on it, you shave it off, and then reattach the tendon. So you're basically effectively dealing with a tendon rupture rehab type protocol. And so we drill holes into the heel bone and we screw these anchors in that then reattach the tendon back to the bone. And then so I tell people all the time, I don't heal things, I fix things. So I fix it back to the bone. Now your body has to heal it, and it takes months and months and months for the tendon to grow right back into the bone, and then it takes months and months to get strong again. And so that's a very, very common procedure. It's one of the most common things we operate on every week.
It's very interesting. Hanna, a question for you. Do you have any tips for athletes that have very flat arches to help with their balance and speed?
Well, it just depends on if the flat foot is kind of structural or if it's flexible, meaning if it's fixed in that flat-footed position or if there's some strengthening that we could do to kind of recreate more of an arch. They may be a good candidate to see a professional, a specialist, and just get evaluated to see if they could take some orthotics too. But specific exercises, it'd be hard to demonstrate those right now, of course. But yeah, I would look into maybe orthotics, some kind of insert into their shoe to correct that flat-footedness.
Okay, great. Dr. Ellington, we were talking about bunions. Somebody asked about corns. So somebody that has corns on the bottom of their foot and it hurts, is there any treatment available?
So it just sounds kind of crazy, but a lot of forefoot driven problems, corns, bunions, hammer toes, pain over the forefoot are actually driven by a tight calf muscle. And so we go back to, people think that as surgeons, all we want to do is cut people, but it goes back to form meets function. And if your calf is tight, that results in functional problems. So a lot of times, it's crazy, but if you work on stretching and keeping your calf muscle and your arch flexible, and that's where we know, every good surgeon knows that there's a good therapist behind them, right? And so that can really help. Second to that, simple debridement. We can, if you are in clinic, we can take a knife, a little scalpel, and we can shave the corn down. That could be a great temporary relief. And then occasionally the corner or the callus is actually caused by bony prominence. If that's the case, then it takes a little more aggressive approach.
Okay. Jeff, a question for you about ankle braces. Are they helpful to help prevent ankle injuries?
Yes and no, in my experience. For instance, if you've had a fresh injury, they're really good at helping to stabilize as you're building the strength of that area back up. But once you get through that initial phase of actually needing it, they can become a little bit of a hindrance, because then it doesn't allow the muscles to do the job, and we start to rely more on that ankle brace versus our own natural ability to make those corrections. If, for instance, you did have a slight inversion movement, you're going to, oh, hey, the brace is there. And instead of letting our bodies take control of it, we're always relying on that outside force. But there is a place for them, and there's obviously, as long as they're not being overutilized, they're really good, which is sometimes what you run into when you see, every high school athlete, oh, hey, I got to go to the training room and get my ankle taped. It serves its purpose for sure.
Okay, terrific. And Hanna, a question for you. Somebody asked us, said their Achilles gets tight and tender and inflamed after they run. Is that normal? And if it isn't, should they see a doctor?
I wouldn't say it's necessarily normal, but I would ask more questions like how far are they running, type of shoe wear. So I think a specialist would be appropriate. That way they could have that conversation. But they could refer to the video earlier too and just try some of the resistance band exercises and the stretches that we demonstrated and see if those are helpful before going to a specialist if they'd like.
Okay. Guys, we're about out of time. One more question for Dr. Ellington. Is it safe to run barefooted?
Holy smokes. I don't know what the word is, tough enough to do that. This might be actually a better answer from Jeff and Hanna, but there's very interesting information and data out there, and there's a lot of anecdotal stories. I think I have barefoot runners. I'm sure they do too, and they swear by it. I would say it could be potentially safe if you do it the right way. And everyone that I know that did it, really, it's not just a slow progression. You have to understand your kids and your gait style and your mechanics, and I think really working with someone who knows about it, maybe have experience and does it themselves, would be the best way to kind of approach that subject.
All right. Well, great information, you guys, and thank you for your time tonight. If you have any additional questions for our providers, of course, you can always call OrthoCarolina. And thanks for watching this edition of Inside the Training Room. Good night, everybody.
Good night. Thank you.
All right. Good job.